welcome to webinar Safety and Aesthetics, Prevention and Complication Management. My name is Dr. Pamela Chayevich-Silp, and I'll be your moderator today. Before we begin, I'd like to take a moment to highlight an idea that sits right at the heart of aesthetic medicine, the balance between safety and efficacy. As aesthetic doctors, we're all driven by results: lift, contour, symmetry, rejuvenation. But every injection, every product, and every plane we choose sits on that fine balance between achieving beauty and maintaining safety. True mastery doesn't come from chasing outcomes. It comes from understanding anatomy, physiology, and potential complications so that we can prevent harm before it happens. In every procedure, we balance two forces: efficacy and safety. Safety ensures those results are sustainable, natural, and complication-free. Efficacy gives us visible results, and it's what our patients see in the mirror. Each component matters: the treatment goal, the product rheology, the injection plane, and even the volume we use. Together, they determine not just how good the result looks, but how safe it remains long-term. As we've all seen, vascular compromise, skin necrosis, even vision loss, these are the moments that remind us that beauty achieved without safety is never a success. Because real beauty doesn't just lift the face, it protects confidence, trust, and harmony. Today's session will focus on how we can achieve balance, particularly in preventing and managing complications from fillers and biostimulators. When a complication happens, the first 5 minutes can determine the final outcome. That's why safety isn't just a concept, it's a discipline. Our speaker today, Dr. Jonathan Kadush, truly embodies this integration of science, safety, and artistry. He's a board-certified dermatologist from Netherlands with a subspecialty in dermatologic surgery and aesthetic dermatology. He also holds a PhD focused on filler-related complications, and his research has been widely published in international journals. He's also an international trainer and key opinion leader of Merz Aesthetics, well known for his evidence-based, anatomy-driven approach. So as we begin, let's shift our focus from outcomes to excellence, from aesthetics to safety. Please join me in welcoming Dr. Jonathan Kadush as he presents Safety in Aesthetics, Prevention and Management Complications. Hello, good to see you.
Good to see you. Thank you. Thank you for having me.
Thank you for coming all the way to Bangkok and teaching us. You had pretty intense 2 days in Bangkok, and
pretty
intense.
Pretty
yeah. So let me hand the stage over to you.
Thank you very much.
Thank you.
Thank you for the introduction, and I'm happy to be here and happy to share this information and presentation with you. And I really like the introduction on how important it is to balance safety and efficacy with science, anatomy, and outcome. We cannot have good results without having both safety and efficacy. And I'm going to run you through the presentation that I'm going to give on this topic, where I'm going to discuss the different types of products we have and how they impact on the treatment and what the potential complications can be. Of course, we also need to discuss and run through how we can solve the complications, because in the end, what we want to do as physicians is to be able to, if inevitably we have a complication, is to solve it ourselves as well. So, talking about aesthetics is like talking about medicine in general. We cannot rule out the potential of complications. In every medical treatment, a complication can occur. The most important thing is to try to prevent them, and if they happen, be prepared. And this is what the topic of this presentation is about. I'm going to start running you through the identification and management of these potential complications we can get in aesthetics. So these are my disclosures. I'm KOL for both Merz as well as InMode, but the content of this presentation is independent. So a complication or an adverse event is what we call when there's an undesired outcome of a treatment. We have a medical treatment or an aesthetic treatment, and the outcome is not what we wished for or has a side effect. Of course, you have to be able to treat it and to do something with that to solve it. And my time actually in aesthetics or in the complication of aesthetics started in 2019. There started my journey when I first met complications and actually was taught how to deal with them. And what we saw back then was quite intense because back in the days we still had a lot of permanent fillers. So we saw complications on, for example, bioalchemid. This is an example of aquamid, both acrylamids, almost kind of like plastics, which were actually used back then with the idea for, you know what, this is a permanent product, it will give a permanent result, and this is maybe good for the patient. But in the end, it gave too much complications and it was not good. And the same is for silicone oil. Silicone oil was also a permanent filler used a lot back in the day and gave actually too much complications. So those are not used anymore, and in many countries they're even forbidden. These complications that I encountered actually led to publications, several publications, and in the end I could also have my thesis on this. We see actually that we have a lot of changes in our aesthetic practices. So for once, we don't use the permanent fillers anymore. We don't use them, luckily, because they give a lot of problems. So now we have temporary fillers. They are degradable, biodegradable, like the biostimulators or like the HAs. The body can break them down into smaller particles and get them away. Now, because time has gone by and we have better products now, you see that the use of injectables has grown tremendously. There's been an enormous increase, and we see on this graph an increase actually exponential, which has been taken part in 20 years' time. You see how the blue line is from the minimally invasive injectables, and the red line is from the surgical treatments. You see that the minimally invasive treatments have grown much more than the surgery. Now, what does this mean for complications? Because more treatments could mean more complications. Now, if we look at the complications, we see that in the literature, if we dive into the literature and look how often complications occur, for the filler-induced vascular occlusions, we see approximately 0.15%. Now, if you look at the late inflammatory reactions, we can see sometimes on HAs as well, on hyaluronic acid, they vary quite often. They can be between less than 1% up to almost 4%. And that depends actually more or less on the product that is used. Because although HAs are molecularly the same, the final touch, the cross-linking, the details are different between different products. That means also that the body responds differently to them. If we look at the CPM technology, that's a technology which actually has a very good safety profile. In the literature, we see almost no inflammatory reactions to them. But the risk is never zero. Now, if we look at the non-inflammatory nodules that we can see from the CAHA products, the calcium hydroxylapatite, if used well and not used on dynamic areas where they can give more issues, then you can see that the risk of having them, the incidence of such nodules, is around 0.61%. You can see it over here. Now, what about non-inflammatory nodules for the hybrid? And that's when you combine CPM technology with Radiesse during one treatment. We see that those in the literature, the publications, that those vary between 0% and 0.23, depending on the details of the technique that you apply. So you see that the amount of complications we see is not necessarily very big. However, the issue is when they happen, it's not nice, and we're not happy for the patient. Of course, the patient is not happy as well, so we would preferably like to prevent them. What type of complications do we have? Generally speaking, we can talk about early complications, that's when they happen within 2 weeks, and we have always injection site reaction. But there's a red cross on this one because actually that's not a complication. Actually, injection site reactions are a part of the treatment. We use a needle, we use a cannula that creates trauma, and because of trauma you see erythema, edema, and other reactions. So that's part of the treatment. Now, since I think maybe more than 10 years, we have monophasic fillers. It means that the HA is the same constitution all over. You don't have particles of HA within an HA gel. And with these monophasic fillers, we almost don't see the Tyndall effect anymore. So that's also a better development that we've seen. But otherwise, there's still the possibility of technical issues, meaning nodules or non-inflammatory nodules. We can still have infections or hypersensitivity reactions. But also, if you look at the late type complications that can occur 2 weeks or later, you still see similar patterns. You can still see hypersensitivity reactions on this side, infections or biofilms, nodules, and on the other side, granulomas, migrations, and abscesses. So you see similar patterns, whether it's an early complication or a late complication. And if you cut this down and you simplify it, what you will see is that we have, generally speaking, 3 types of complications bothering us most frequently in our daily practice, and of course, which are bothersome for the patient as well. And those are the non-inflammatory nodules, which can occur both with HA as well as with CAHA, with the biostimulators, or migrations. Those are the most frequent. After this, we also see the late inflammatory reactions, and those are quite tricky because we still do not fully understand what the etiology is. What causes those inflammatory reactions? Is it the hypersensitivity? Is it a foreign body reaction? Or are it more biofilms and infections? So this is a difficult one. And lastly, but not leastly, we see the vascular occlusion, and of course, this is a dangerous one. This is the one we want to prevent at all costs. If you look at the most challenging, of course, you can cut it down to vascular occlusions and late inflammatory reactions, or rather LIRs. Those are quite tricky, both of them. So the goal of this presentation is actually to run you through the protocols, the approaches, and the theories behind them to know what to do when a problem occurs, or, excuse my French, in English, when you say, when shit hits the fan. When we're talking about a complication, there are actually 3 factors involved. You have the patient with its own genetic makeup and its predispositions. You have the product, which can be different one from the other. And we have the doctor, the physician, the third P, which performs the treatment, which also has influence on whether we get a complication, yes or no. If you look at the product has quite some variabilities, some potentials. The level of porosity, the shape, the topography, stiffness, chemistry, also size can really influence how the body reacts to it, if it will accept the product, yes or no. This has also nicely been described by a paper from Nicolau in 2007, where he actually described the interaction between human biology and materials from foreign nature, like injectables. And what we also see is that although the products we use nowadays are based on natural body constituents, like uronic acid, and also the CAHA biostimulator is composed of synthetic version of what we have in our own teeth and our own bones, so it's biodegradable. The finishing touch, the way the product is made in the end, can still be different, and that's why we see also in these big reviews, like from Prokoska 2022, that some fillers create more problems than other fillers. And that's something we have to be aware of as doctors, to choose the right products for our patients. So in conclusion, not all fillers are the same. Even if they have the same molecular basis, the end product is different, leading to different safety profiles. So we have to be aware of that. Now, let's run you through the practical approach for nodules. What do we do when we have a nodule? Now, the nodule usually is a technical issue because it's the physician who decides which product he uses, how much he injects, and in which layer he puts the product, meaning that you can usually prevent nodules with the right technique. But if it occurs anyway, if you have a contour irregularity without any signs of inflammation, then of course the first thing is what we do is massaging. We want to massage it away. And for the HAs, usually that works quite well. Now, if it doesn't go away with massaging, you can inject hyalase. However, with hyalase you can dissolve it. In some papers you will find that aspiration is an option as well, but in practice, with the way we treat nowadays, that's not really something that's easy to do. Because we put small deposits on the bone, or we do cannula deposits of thin threads. So this type of deposition you cannot aspirate, so it's not realistic. There is another thing you could apply if, for example, the product has been a bit encapsulated or is a bit fibrotic. Then you can try, which has been published by Casuto, to use laser fiber to heat up the product and then break down the capsule so that you can dissolve it more easily. That's what we call ILT, intralesional laser therapy. Now, once you decide to remove the product with hyalase, the next question you have is, how much do I use? How much units do I need? And how do I reconstitute my hyalase? Because we have different types of HA, but we also have different types of hyalase. So how do we find our way to the right approach? It can be challenging. A lot of publications have been done on this topic. Now, also this publication recently from Chrysompos, from 2024, quite recent, actually a nice publication detailing the different types of hyalase. And generally speaking, what you can say is that for correcting 0.1 cc of HA, you need approximately 10 units of hyalase, on average. Where I'm working in the Netherlands, we have vials of 150 units of hyalase. So the moment I reconstitute that in 1.5 cc of saline, I can easily dissolve my filler 1-on-1. So 0.1 HA, 0.1 hyalase. So that's an easy rule of thumb that you could apply. Now, if you have another type of nodule, a nodule, for example, from CAHA, calcium oxalate, what do we do then? Now, diving in the literature, in the papers, you see if caught early, you could express it manually or maybe aspirate it. Also, this is something with the techniques we have nowadays, I don't think is realistic, so we shouldn't look at that. But massaging, using warm compresses, vibrational therapy can be done to try to distribute actually the product over a larger surface area and diminishing the nodule. So that's actually the goal we should have, the way to go. There's also a thing we call the antidote theory, injecting fluid, H2O or saline, but sometimes also it's mentioned H2O, trying to dissolve the product and spread the product evenly. But what always be careful with is excising it, because the moment we excise it, we create a scar, and a scar is permanent, whereas the product is not permanent. The product degrades. And the good thing about CAHA, and that's why I really like to use it as well, is that it's quite predictable. It's predictable in its behavior and also usually quite predictable in its complications. So when do I expect a nodule from CAHA if it occurs? Usually around 2 to 3 months. But at 6 months, it's already going down in volume. And usually after a year, it can be gone already. And patients, when they have it in their face, they don't see it very often. It's usually only feelable, palpable. And the moment you don't see it, and you know it's going to be gone in a couple of months, you can also just let it be and let it disappear by itself. However, if you want to try to actively reduce the size of the nodule, then this approach could help you. Because in this study, they showed that if you compare massage alone, or massage with saline, or massage with sterile water, the sterile water in combination with massage is the most effective to reduce the size of the nodule. However, sterile water is painful to inject, so or you have to add Lido to it, or you do the saline twice, right? And then you have the same result as well, maybe with a week interval. But this study was developed further, led to the next paper by McCarthy, in which they showed the saline wash. And it means that instead of using small volumes of H2O, you use large amounts of saline, and I'm talking not about 0.5 or 0.6 cc's, no, I'm talking about almost 5 cc's of saline, maybe more. You inject large amounts of volume to help disperse and reduce the particle concentration. And by reducing the particle concentration, you reduce the nodule. So this is more or less becoming the golden standard for treating nodules of CAHA. Next topic, if you look at the hybrid, which also can make nodules, luckily the frequency or the incidence of nodules is very low, but also, which is a good thing, is that you can well treat them with hyalase as well. It reacts well to the hyalase. And for some people that might be a bit strange because, of course, we know that the particles cannot be degraded with hyalase. So how come we have a good response on hyalase? Well, that's actually for the same reason as described by the previous study of McCarthy, is that the particles are now embedded in HA. And the moment you take the HA part away, there's room for the particles to spread over a larger surface and reducing the concentration again of the particles per square centimeter, diminishing the nodule. So with these hybrid nodules, hyalase appears to be a good method. Now, if we look at the take-home messages for nodules, generally speaking, you have to be careful with your choice of product. The rheology so understand the filler that you're using, the amount of cc's, and the injection depth is very important as well. But hyalase is still a very important component of the treatment approach, so make sure you have enough of it in your clinic. Next is inflammatory nodules, a little bit more challenging, right? Because inflammatory nodules, when you look at those, especially 10 years ago, they were a very big, challenging topic. And a lot of publications were done on this topic. And these publications showed actually that there's a trend for some products to be involved more often in inflammatory reactions, having several cases being published, actually with a total of quite significant cases. But nowadays there seem to be less cases mentioned or reported, and maybe that the products that were involved in the past have made some updates, maybe. But the thing is that when they occur, we still don't completely understand the etiology. And because we don't fully understand the etiology, the treatment is also sometimes quite challenging. If you dive into the literature and you look at what's been written on this topic already, what you will find is that the main things involved in the hypothesis on what causes these kind of problems of inflammation is or biofilm activation or foreign body reaction, hypersensitivity reaction, or adjuvant-based filler reactions. So these are the main drivers in the literature to be the culprits of a granulomatous immune response. Now, if we dive into this a little bit further, what I was quite challenged with is the fact that whenever you have an article publishing on inflammatory reactions, it was always called hypersensitivity or often called hypersensitivity without the right diagnostic tools for it. So they didn't do the golden standard allergic testing. And we tried to do this. So we gathered as much as patients as we could who had experienced a late inflammatory reaction in the past, and we injected them with commonly used fillers in the arm, intradermally, to see if we could reactivate this inflammatory reaction again. Because if it's hypersensitivity or allergy-mediated reaction, it should be effective. It should be a problem all over the body, not only in the face. So we did this testing, and actually we found 0 reactions. 0 after 6 months follow-up. So somehow testing with these fillers again on another site on the body didn't give the same response of inflammation that the people had in the face in the past. And this way we test not only type 1 reactions, but also type 4 hypersensitivity reactions. So although the cohort is small, and that's just because we couldn't find any more patients, it doesn't happen very often, this complication, there doesn't seem to be a big role for hypersensitivity based on this study. A second study, also quite interesting, also investigated the immune response that we can have on filler products. It gathered samples from 47 patients, and it did immunohistochemical staining to see what type of immune cells do we have around these samples. What do we see around the filler? And it checked between innate immunity cells and adaptive immunity cells. So it tested for CD68 macrophages and the T cells. And the only thing they found, the only thing that's colored, was the CD68 macrophages. And that's the innate immunity, innate immune system. So there doesn't seem to be a big role for the adaptive immunity, similar to what we saw in our hypersensitivity publication. Another important topic on etiology of late inflammatory reactions is infections, of course. And although it's 100% certain that there can be infection developing in the fillers, and also strange infection, atypical mycobacterial infections have been mentioned and reported and also diagnosed in patients, and can be very challenging to treat. But usually when you have an infection like this, even an atypical infection, what you will find is skin involvement. The skin will be showing signs of infections as well. Whereas in the classic late inflammatory reactions, the skin is usually fine. It's just a subcutaneous swelling, what you will see. Subcutaneous swelling with a bit of redness. But no signs of infections like pustules and crusts on the skin. Now in those cases, they investigated samples of patients again to see what bacteria do we see. Do we find signs of a biofilm or infection? And they found a lot of bacteria with a very sensitive IS probacterial analysis. However, it's a very sensitive test, and it can also just be contamination. It's definitely contamination because we find bacteria, but is it also infection? Because these are two different things. Now, if you look at how can there be contamination in these products, of course, what we know is that the product is sterile. So it's definitely not from the sterile product that we inject. It might be, though, during the injection, it's very difficult to stay sterile because although we work aseptically, the skin has a lot of bacteria, a lot of commensal bacteria. So it might be that during the injection, we still create some contamination. It's possible. But what's also possible, and has been shown in plastic surgery publications, is that from breast implants, they find sometimes on the capsule of breast implants bacteria that are actually part of the mammary glands. So they seem to be traveling from the mammary glands a few millimeters down to the breast implants. And maybe that happens in fillers as well. Fillers placed in the fat layer, and actually some bacteria that are normally available or that are present in hair follicles or in adnexes, they travel a few millimeters down to get onto the filler. But still the question is it only contamination or is it also infection? An infection would be a bit strange if the majority of the layers are infection because they tend to react quite well to immunosuppressant medications. And that shouldn't be the case with a true infection. Also, this publication, for example, mentions that they're quite convinced that layers are infections because they got a good result, a good success rate of 17 on 22 patients with an antibiotic treatment of the late inflammatory reactions. However, if you dive into the material or into the publication, you see that actually they applied Hylase as well, and also an immune modulating antibiotic. So the moment that you have Hylase and an immune modulating antibiotic, it's very difficult to be sure what did the trick. Did the hyalase remove the product, or did the immune modulating antibiotic was able to suppress the immune system a little bit without necessarily killing bacteria? So we have some biases here which make it difficult still to get a clear-cut idea on what's the main etiology behind the leers. So we still not fully understand, but what I would usually do when there is one, of course, make sure there's not an abscess going on there, because if it's an abscess, then you have to treat it otherwise. But if there's non-fluctuating swelling and redness, I would generally start with an immune modulating antibiotic still, because we're not fully sure about the etiology. So you just be safe, better be safe than sorry. You could start corticosteroids at day 2, which is also usually quite effective. But my main goal at this point, the main thing I want to achieve, is to stop the inflammatory reaction. That's my goal, stop the inflammation. Now, after this course, I wait and see, but if it comes back, then my goal changes. I got another goal now. Now I want to remove the HA, and by this stop the inflammatory reaction, because apparently the body doesn't tolerate the filler very well. So the next goal is to remove the filler. And then what I do is restart the antibiotic and the corticosteroids. Why? Because if there's still some bacterial contamination out there and I inject hyalase, I might open the way for the bacterial contamination to really become an infection, and then I get a new problem. So I first want to have an umbrella of immune modulating antibiotic with a bit of corticosteroids before I inject the hyalase. Still, there have been cases described with this approach that still don't fully go away. Then you could maybe try ultrasound-guided hyalase injections, might still help, or the ILT laser approach again. And if this doesn't still help, then you could consider immunosuppressants other than corticosteroids for maybe a longer period of time, or further diagnostics to get a bit of a better image of what's exactly going on there. However, even if it's for an inflammatory reaction, I still apply the same amount of hyalase as I do for the nodules. 0.1 on 0.1 based on 155 units of hyalase and 1.5 cc of saline. But like I mentioned before, don't forget alternatives to corticosteroids. Corticosteroids are, of course, our working horse. They're like the best and easiest and quickest and efficient way to treat inflammation when there's no infection involved. However, sometimes if there's very persistent cases lasting very long, we know that we still have a degradable product there. And we know that the body is still going to take care of the product and break it down, but it might take 6 months, a year, 1.5 years. And you don't want to give corticosteroids that long if it's unnecessary. So then, in such cases, you might consider going to other types of immunosuppressants to change instead of the corticosteroids. What about CAHA inflammatory nodules? Well, CAHA nodules are a bit different because they don't have this classical big inflammatory response as the HAs. They usually give small nodules with a bit more inflammation, redness, swelling, and for those, the common way to treat them is corticosteroids with or without 5-FU. Take-home messages for this problem is there seems to be a big role for innate immune system mediated inflammation and potential bacterial contamination which pushes the inflammation a bit further. But the favorite approach for treatment is still a combination of immune modulating antibiotics with corticosteroids. And of course, if necessary, hyalase. Challenge as aesthetic physicians, of course, is the peripheral vascular occlusion. This is like the headache, a bad sign, a bad thing for the most of the doctors to deal with because it's challenging. It's even more challenging than the leers. But what I always say is the moment you have a peripheral vascular occlusion, of course it's an emergency, but it's not super acute. So when it happens, relax, take your cup of coffee, dive into your protocols, and then treat the patient, right? You have time, because between the onset of the occlusion and then the occurrence of the necrosis, you at least have 3 to 4 days, maybe more. So there is time. And there's also very good protocols you can use, protocols that already have designed for you how you can treat your patients, that you can just print, put in plastic, and have in your clinic, both for HAs as well as for CAHA. So you don't have to reinvent the wheel yourself. You can just use these protocols to your benefit. Now, when we look at the etiology, the idea is that we or have an external obstruction of the filler on the vessels, or external or internal large filler embolus which blocks the vessel. Now, a lot of doctors, including myself, will argue that external obstruction is a real thing because we're using soft materials, soft fillers. And soft fillers pushing and closing a vessel with normal blood pressure is quite difficult to imagine. So I'm not sure that's really an issue, but still we mention it. Now, if you look at the papers around what are the signs we're looking for when there's an occlusion, I would say any sign of discoloration, whether it's a livedo discoloration or on this side a blanching, I would always consider vascular occlusion, right? A big study, multinational study, showed that even experienced injector will soon or later get a vascular occlusion. So it's not a strange thing to experience. It will happen. It can happen. And you see that mostly it happens within the mid-pupillary lines because the vasculature there is quite intense, a lot of crossovers. So it's much more easier to get an occlusion within the mid-pupillary lines. In this Dutch-based study, because where I practice is the Netherlands, and it's a small country, so to go from one side to the other usually takes 1.5 hours, and we have a good referral system and good network of colleagues that all know each other. So we're quite confident that we see the majority of complications of vascular occlusions in the country, which gives us the possibility to calculate the incidence of vascular occlusions, which we think is around 0.015, based on our study. That's not a lot, it's not a little as well, but I think it quite nicely reflects the daily practice. The important thing, though, is that only 3 cases of those 44 patients, and I think this study was done in 2020, published. I think now the number is already around 200, 250, because we keep track of these vascular occlusions. Most of the cases were with needle, only 3 with cannula. And if you look at what cannulas, 25 and 27 gauge. So these are quite relatively thin cannulas. And nowadays, when I treat in the face with fillers, I actually only use 22 gauge cannula for the whole face, the neck, wherever I treat, except for lips and teardrop. Because the bigger the cannula, the smaller the risk of an occlusion. Occlusion risk is never 0, but the bigger the cannula, the smaller the risk. I will run you through a case that I treated of vascular occlusion, and here you see this discoloration on the tip of the nose from a patient treated by a physician. She wasn't treated by myself, but by a physician in the same city with 0.5 cc's of HA and a needle on the tip. Now the next day, she goes back to the doctor, quite worried. Something's happening on my nose. I don't trust it. I'm a bit scared. What should we do? And the doctor said she was right. Something strange going on. He thought of an occlusion. So he started treating her with the golden standard for the day. Today is the flooding protocol by De Lorenzi. Day 2, still not very good. Patient becomes scared. They do again a round of flooding protocol, hoping that it would solve the problem. But you see it gets worse. Day 4 now. Patients start panicking. She finds me somehow, and I start treating her with ultrasound-guided injections. Now this is actually high-late injections guided by ultrasound. How does it look like? It looks like this. So what I have here is actually, you see on ultrasound, the hypoechoic aspect of the HA. But I'm not looking for the HA. I'm looking for the obstruction in the blood flow. So what you see is here is there's an obstruction in the blood flow. However way I turn the handpiece of the ultrasound, I cannot show a full open vessel. So what I'm going to do is I'm going to inject this point where there's obstructed blood flow with hyalase, and after minutes, even just minutes, you will see that the blood flow is continuous again. The vessel is fully opened, and that's the goal, the end goal of the treatment with hyalase on ultrasound mediated. Now you see the next day already a significant improvement. Patient very happy, very relieved, but I'm not fully content yet because I still see some 2 new pustules. So I go in there again with 50 units, and my goal now is actually also to look at the different levels, because the vasculature in the face or in the body, generally speaking, is organized in angiosomes, meaning like the tree and its branches. You start with a big vessel in the deep with more smaller vessels in the top. And it might be that I released some vessels in the top, but not the big branch in the deep part yet, or vice versa. I've released the big branch of the vessel in the deep, but not the smaller vessel superficially yet. So I go back with this double layer approach. I want to put my product in different tissue layers. And then I'm happy. This is what I want to see, right? No more pustules, day 6, and day 7, it's almost fully gone, and she heals without scarring, and that's the goal. We want the patient to heal without scars. Now, what do we do, generally speaking? If you look at the protocol-wise, how do I fit my protocols? Of course, if there's an occlusion, first thing you do is you stop injecting. Immediately stop injecting. And everything we're doing is actually to make sure the blood flow is improved and the obstruction is removed, right? More blood flow, less obstruction. So compresses, warm massages, and hyalase. Now, what you can also consider is nitroglycerin, oral aspirin, antibiotics, and corticosteroids. And all of these things, you will find them in the publications that I just mentioned before as well. All the publications nowadays on how to manage vascular occlusions have similar advices. But what I usually do is I wait with the antibiotics until I see that the ischemia really proceeds towards necrosis. Because sometimes you have an occlusion, but it doesn't go to necrosis. So my point for starting to give antibiotics is usually when I start seeing pustules. What's missing? There's something missing in this whole story. That's, of course, the hyperbaric oxygen chamber. Hyperbaric oxygen really adds to the oxygen flow to the area. So where the blood flow sometimes is limited, hyperbaric oxygen can increase that oxygen to the area. And we published this together with my dear friend and colleague, Dr. Nabil Faki, in which we actually published a strategy for using hyperbaric oxygen in cases of persisting or difficult cases of vascular occlusion. And what I usually do, of course, is similar to antibiotics. I try to treat them and to clear the problem, if I catch it early, of course, with hyalase only until the pustules come. Once I have pustules, then I try to send to hyperbaric oxygen. I add it as a treatment modality. And this you can find quite easily on PubMed. Of course, you have your contraindications. You try to treat within a certain time frame. You have 2 ATA pressure, 60 minutes treatment sessions, and try to have a cumulative dose of 10 sessions in total. Now back to the flooding protocol, because that's our golden standard. That's the core treatment approach for complications. And when you look, what do we do when we have the flooding protocol in as method? We inject an amount of hyalase depending on the size of the affected area. So the bigger the affected area, the more we inject, 500, 1,000, or 1,500 units of hyalase. And you can retreat every 60 to 90 minutes until the skin clears out a little bit. But usually in practice, I do this 3 to 4 times maximum, and then I have the patient coming back next day. Now, if we go back to this ultrasound-guided injection thing that I just described and showed you with the ultrasound images, what's the difference between both? And which is superior? That's also important to know. Now, in this study, what we did is we compared challenging cases, so the cases that wouldn't react to the flooding protocol, we treated them with ultrasound-guided injections and compared the results. Now, of course, they came to us already because what you see is that there were 39 cases which didn't respond very well to the flooding protocol. They injected 1,500 units of Hyalase on average with only 7.7% little improvement. And little improvement is not good enough. And then the rest of the patients, 0 improvement. So they came to the authors of this paper, and then they were injected with ultrasound-guided Hyalase injections. And what you see then, with only 122 units of Hyalase, you see a 100% improvement of the cases. All cases were resolved without scarring. And that's for the challenging cases, the cases not responding to regular flooding protocols. So that shows you that actually ultrasound-guided injections is superior to the standard of the flooding protocol. But not everybody has ultrasound. Not everybody has the experience to work with ultrasound. So the flooding protocol is still and remains still the golden standard. But the trick is, if you apply it, always apply it multi-layer. Now, the next question is, why do we see differences between some cases going to necrosis and some cases staying in libido, like I have here? Some cases will just show this and not proceed to what we see here. And why is that? We don't fully understand exactly why, but we do see some things that give an indication. First of all, like I said before, the face is organized in angiosomes, different angiosome units, which divide the face in areas and which act more or less as a protection mechanism. So what it does, it can close down the area using what we call choke vessels. So on the border of the areas, we have vessels that can close down, constrict, spasm. And if there's a problem in this angiosome, the closing of the vessels, like closing a gate, prevents the problem to go to the neighborhood, other neighborhoods, other angiosomes around it. So these choke vessels are really a protection mechanism for the body. But the funny thing is, if you look at the angiosomes within these choke vessels, within these borders, the patterns that we see for, let's say, for the regular vascular occlusions that we see on the face, they are similar to the patterns that we see which define actually what an angiosome unit is. So the regular angiosome units, we see them back as patterns of vascular occlusion, meaning that when we have a vascular occlusion, it seems like the whole angiosome unit is shutting down. And what you've seen from certain studies investigated vascular occlusion in a rabbit ear model is that when HA is injected inside the vessel, it actually is quite inflammatory, because we know HA as a relatively non-inflammatory product and biocompatible product when injected in the fat layer. But the moment we inject it intravascularly, it becomes very inflammatory. And because of this inflammation, choke vessels close down. So it might also be that exposure of HA intravascularly during a vascular occlusion or a vascular accident actually causes a spasm in this whole angiosome unit. And the whole angiosome unit shuts down by spasm, not only by embolism. And that's something we have to find out. That's something that's not fully clear yet. So what's the main cause then for vascular occlusion? Is it actually, again, like we discussed, external compression, which most doctors will argue against, internal obstruction by an embolism, or maybe do choke vessel constrictions also play a role in this? Are we really dissolving HA, or are we doing something else? And if you look at this study in mice, where they actually treated vasoconstriction, vasospasm in the brain, they were able to release that vasospasm with Hyalase. So Hyalase alone was able to relax the muscles in the brain and prevent brain ischemia. And who knows, maybe Hyalase has a similar effect in humans. So we started treating patients with non-HA vascular occlusions as well with Hyalase, actually applying the same protocol as we do for HA occlusions, injecting Hyalase ultrasound guided in a few cases with 2 times CAHA occlusion and 1 time PLLA occlusion, ultrasound guided, and we got actually the same good results, no scarring. Of course, this is a case report. It's only 3, and it's 3, and 3 is not a lot, but it's definitely something we should look further into and do more studies on to see what's exactly going on with these vascular occlusions. Last little bit, central vascular occlusions, or what we also call blindness. And this is really the nightmare of all doctors. If peripheral vascular occlusions is already the headache, this is really the nightmare. Luckily, it happens seldom. It's very, very, very rare. But we have to understand it's a very potentially dangerous complication and really take this into consideration. But also for these type of complications, we have algorithm, we have protocol. Use them in your benefit. Print them, download them, and print them. Put them in plastic and have them in your clinic. This, however, is really an acute issue. And what happens in these situations is that what we believe that happens is that intravascular placement of filler with injection gives more pressure than the blood flow and pushes the filler all the way back the arterial pathway, leading up to the central retinal artery. And the moment you stop injecting, the blood flow takes over and pushes the filler towards the retina, blocking the whole central retinal artery and giving blindness, which is a horrible complication. Now, what are the most often involved areas of injection? What we see is that we have most commonly, it's about nose, forehead, and glabella. These are the most commonly involved, again, mid-papillary line, mid-face. Any type of product can create a complication. Like you see here, all the products I mentioned, all the products can create, in theory, a central vascular occlusion or blindness. So it's not a product problem. There's been some nice publications from Jones and from Jujin, which actually describe how symptoms of blindness, how far the symptoms go, can also explain a little bit of what arteries are involved at that moment, right? Is it partial blindness? Is it full blindness? Is it blindness with neuropraxia on muscular level, eyelids may be immobilized, a lot of things that can guide you through getting an idea of what's really going on there. But there are definitely some challenges. So for once, in the past we thought that we had 90 minutes before infarction of the retina. Nowadays, with the new studies, we actually think it's more towards 15 minutes. So the time frame to create a positive outcome has become smaller. A lot of doctors have issues with just any physician doing retrobulbar injections, and it's of course not for nothing. A retrobulbar injection can lead to hematoma. Hematoma can lead to blindness, but in this patient with vision loss, there is already blindness. So that also makes it challenging to avoid big procedures on those patients. Another thing is that the central retinal artery is partly covered by a myelin sheath, and that's not penetrable for Hyalase. So only a small portion of the central retinal artery is available for Hyalase and Hyalase penetration. And if you don't act quickly, another problem that can occur might be a thrombus because of flow and stasis of blood flow. So then you get another problem on top of that. So there are quite some difficulties. And the main question usually on congresses and events is, should we do a retrobulbar injection, yes or no? And that's a very difficult question with not a clear-cut answer. But if you look at the different consensus papers on this topic, most of them are still kind of pro-retrobulbar injection, because you could do mostly more good than harm the moment there's already full vision loss. But if you look at the papers covering and analyzing the literature, because there have been a few cases of recovery, most of vision loss cases, people remain blind, but there have been cases of vision recovery, a few. but we don't fully understand why. We don't understand why some patients with hyalase injections get vision recovery and some don't get it at all. So there are a lot of things we don't understand yet. But there seems to be a trend towards benefit of quick action and high doses of hyalase. These two seem to have the most potential for positive outcome. And if you do this retrobulbar injection, the consensus usually is to use the lateral inferior quadrant of the orbit. Now, what is generally speaking, if you look at the protocols in the consensus papers, we have one here from Lee Walker, from Greg Goodman, and from Philip Snodzy. What is usually the mode of action? Of course, first you want to assess the eye function, because you want to make sure how bad is the situation. Is it full vision loss? Is it partial vision loss? If it's partial vision loss, don't do too many crazy stuff. Send the patient to the ophthalmologist for further analysis and treatment. If there's full vision loss, then the advice usually is to do as soon as possible both, actually 3 things with hyalase: local, regional, and retrobulbar injection in high dosages, to make sure that you do everything that's possible to resolve the problem. Additionally, things you can do are ocular massage, pressure-lowering eye drops, CO2 rebreathing, oral aspirin, and of course the hyperbaric oxygen chamber. Everything to improve blood flow and reduce pressure in that area. But of course, don't forget as well to do some neurological diagnostics, because it has been described quite often that these cases also have cerebral infarctions due to the filler. So, a difficult topic, but again, there are protocols. There are things you can do about this and to improve the outcome of the situation. But what you also need, aside from the protocols, is the right materials. You have to be prepared in your clinic. You have to actually have an emergency crash kit, an emergency filler kit, which we call the UFEC. And this has been published, and it helps you to do what you need to do when, like I said again, excuse my French, shit hits the fan. Right? When a problem happens, you don't only need protocols, you need the right materials, like on this picture. So this is a publication, again, by my friend Dr. Nabil Fakih and myself, with others, of course, describing what you need for such a filler crash kit. But Dr. Nabil Fakih did an update on this together with pharmacologists, and actually described in this review of the literature what are the essentials for a filler crash kit, based on blindness, VAE, general VAE, and anaphylaxis. So they described actually what medications should be obligatory, what should be recommended, and what should be advisable, based on the classic ORA classification for medications in a clinic. Now, if there is a vascular occlusion, and you look at the type of drugs that are involved, like you see in this column, then the O type, which is obligatory, which they consider obligatory, is of course hyalase, aspirin, prednisone, ibuprofen, and some others. What they think is optional is the clopidogrel, hydrocortisone again, and some other medications, clindamycin, and advisable, the local topical antibiotic, and some other prednisone. So, given this table, you can use this in your benefit to organize your clinic in a way that you have the right materials. And of course, this is what they've actually generated for their local situation. It might be that in your country, that's why it's, for me, not a big asset, a big add-on to go into these medications in detail, because some countries will have different types or different brands, or not have everything available. You have to change it to something else. So look in your local situation, look at your local pharmacy, and see what is available for you, which is more or less comparable to what they mentioned here. If there's blindness, there are other things you should add, of course, things to reduce intraocular pressure, vasodilators, and other stuff. But again, this is a beautiful publication to dive into and to look through with the local pharmacologist what is available to you. Now, Also for anaphylaxis, they have medication which you should have, because once you use HA, you might need hyalase. If you need hyalase, then there might be anaphylactic reactions to it. Also to lidocaine, it might be possible. So be prepared for anaphylaxis as well. And of course, these are different medications you can use for this. And this could be a flow chart for dealing with anaphylaxis, but many clinics already have their own type of flow chart to assess those and to treat those. Now, as a summary for the emergency kit, this is what they summarized in their paper, everything you might need in your clinic, and which is obligatory, which is recommended, and which is advisable. Again, take this to your benefit, use the publication, and look in your local pharmacologist, with your local pharmacologist, what you might need and what you can get. But the key message, of course, is be prepared. Non-inflammatory nodules, inflammatory nodules, and vascular adverse events are treatable with hyalase, and hyalase is actually the most important thing in your clinic. Ultrasound can be definitely of an advantage for you, especially for vascular occlusions and for other type of complications. But in the end point, know your anatomy, know your patient, know your product, and have the right materials in your clinic. Be prepared. Thank you.
Thank you so much, Dr. Jonathan, for a very insightful, detailed, and also very concise lecture. We learned about, mechanism of complications, how to prevent, and also how to manage, and then also how to set up an emergency cart. That was amazing.
Perfect.
So we actually do have some questions. I think a lot of our listeners, they do a lot of injections in their practice. So I think they want to know a little bit more, detailed management. So the first question was the use of hyaluronidase for treating vascular complications, not from HA, but from CAHA, because that's like we're using that a lot more. And just going to the last question as well, like how is it safer or is it different from HA, and how would you manage?
That's a very good question, and a very important one as well. What you see nowadays with the new insights that we get from what's the cause for vascular occlusion, and also the role for actually the spasms that they can get from the choke vessels, these occlusions. There's a tendency to actually have similar approaches for CAHA occlusions and HA occlusions. So we actually copy the HA protocols to the CAHA protocols, and actually we tend to treat both of them with hyalase in more or less a similar fashion.
Yeah, because from your lecture, that study was very interesting. How the vasodilation from the hyalase, as well as that case report that you mentioned, that was very interesting.
Yeah, it might quite be interesting to further see what comes out of this with more research. That is hyalase really capable of relaxing vascular occlusions in some way that we still don't fully understand yet, like it did in mice. And what is actually the biggest problem with the vascular occlusion? Is it constriction leading to necrosis, or is it the embolus? And also that's something we don't fully understand. Or is it both? Maybe it's both.
Could be both, yeah. But do you use the same concentration of hyalase for both?
Yes, I would use the both.
Okay.
Yeah, the only moment I would change my concentration of hyalase, if you look at the consensus protocols on that topic, would be for a retrobulbar injection. Then you want to actually, because the amount of volume you can inject is limited in the retrobulbar space.
Right, so you have to be careful.
Yeah, you don't want to inject too much volume, so the volume you inject needs to have a high concentration of hyalase, so you will concentrate it more.
Right.
But for the regular peripheral occlusions, I more or less do the same thing.
Yeah, and I think a lot of us will refer to an ophthalmologist or ophthalmologic surgeon for retrobulbar. I think we're a little bit cautious of that too, and also the role of hyperbaric oxygen. In your lecture, it sounds like it should be administered if you see vascular complications. Is that what you would do?
Well, definitely if I don't get the situation under control within a couple of days. So I think it's quite an elaborate process and sometimes quite tricky to get hyperbaric oxygen set up, and also quite intensive for the patient.
Right.
So I think there's an argument to be made to maybe first start 1 or 2 days with Hyalase alone and see how it develops. And
see how it goes first.
yeah, and if you see
Okay.
you get it under control, then you can leave it. But if you see that the pustules start coming, then it's smart to move towards
Okay, so it's not too late after maybe 48 hours and see?
Not necessarily.
Okay.
No, because if you look at the time frame, usually the pustules, which are a pre-sign of ischemia, or the strongest sign that you're going to proceed into necrosis, they usually don't start before 3 days on average. Sometimes even later, sometimes a little bit sooner, but mostly day 3 or later.
Okay. Another question that was asked a lot is about the Kaha nodule. You were saying that there are inflammatory ones and non-inflammatory ones, and then there's different stages as well.
Yeah.
And I remember that you were talking about how either saline or sterile water flushing seems to be the best. So when is it the cutoff between whether you want to do the mechanical with saline flush or water flush versus adding intralesional steroid?
Steroids.
Yeah.
That's also a very good question, because of course we want to avoid injecting steroids as much as possible because of the risk of atrophy.
Yeah.
And that's always something that we have to balance out. And we know that, for example, the collagen metabolism is a slow process with everything we do. Whether it's biostimulators or maybe therapy or maybe some other energy-based device, it's a slow process, so we have to educate our patients also that you won't have the result tomorrow.
Yeah.
You'll have it in between 6 weeks and 3 months. So I think also that within that time frame of 6 weeks,
6 weeks and 2 months, so
Exactly.
6 to 8 weeks around.
I think within those 6 to 8 weeks, you can mostly focus on saline or H2O wash.
I see. Okay.
The moment you get after this 6 weeks, also in combination with some redness or swelling, then it's probably also already a settled collagen part of the nodule. That part you could maybe diminish a bit with corticosteroids.
I see. So if you do see inflammatory type of reaction, then maybe afterwards you can do the steroid. But I take it that it's not very common that you use the intralesional steroid injection.
Almost never.
Almost never.
Almost
okay, that's
never.
good to know.
Yeah,
okay. Okay.
There are some cases, and of course, usually if there's a nodule which is already showing up at 4 weeks and persisting until 4 months, and it doesn't become inflamed, so no signs of redness or swelling, you can still leave it be. If you have chosen with the patient to not try to remove it because maybe it's not visible or not bothersome. So it's really a bit of managing what the patient wants, the expectations, and I think as long as you're in a short time period, the first 6 to 8 weeks, and as long as there's no redness or swelling, I don't think that corticosteroids will add anything anyway.
Correct. Yeah, I completely agree with you.
Okay.
Yeah. Okay, I think those are all the questions we have for you today. Thank you so much for taking the time to give us a very detailed and insightful lecture on complication management as well as prevention. I'm sure all of us learned a lot from you. So I'd like to end this lecture and thank you for coming.
Thank you for having us.
Thank you.
Thank you.